Hi, everyone. Hope you're all keeping well and everybody's ready for another ECG. So we haven't had an ECG presentation for a little while, and I decided this might be a good one for us to have a look at. It's quite an interesting one, not a particularly advanced one, but just one that just makes you think a little bit. So I hope you guys had a chance to have a look at the ECG and maybe came up with your own ideas of what was going on. So let's jump into it. So we've got a 58-year-old woman with chest pain, hypotension, and pulmonary congestion. So whenever you get a patient like that, you immediately start thinking of myocardial infarcts, you start thinking of pulmonary emboli, you start thinking of arrhythmias, because those are the most common ones that will actually lead to you getting those. And of course, acute left ventricular failure for whatever reason, valvular disruption, so on and so forth. But the majority of the time, you're thinking along the lines of arrhythmias, pulmonary embolism, or an arrhythmia. So let's have a look at our patient here. So they've given us a rhythm strip, and they've given us the ECG itself. So let's have a look and see what we can find. So we'll start first with the axis, as we always do. So let's just get that drawn over here. So let's just get our little grid going over there. And as we always do, and just have lead 1 and lead AVF. So we're going to have a look at the two of those. Let's just get there. So we've got lead 1 that we're looking at. Before we worry about morphology and things like that, we're just worrying about the axis. So lead 1 is pointing in a positive direction. So that means the axis is either a left-sided axis or a normal axis. We know for sure that it's not going to be a extreme right axis, and we know that it's not going to be a right axis. Okay, and then if we look at lead AVF, so that's a little bit more because it's actually a biphasic. So remember, whenever we have a biphase, that means lead F that's looking in this direction is seeing electricity coming towards it for a while, and then seeing electricity going away for a little while. So actually what that tells us, and it's slightly more negative than positive. So if we have to be very strict about it, we'd actually say our axis is just about there. We can work out the exact axis if we want, but it's not really going to make much of a difference to us. So we've got an axis that's sitting about there, which is still relatively normal. It's not really left-sided, because from minus 30 degrees to 90 degrees is considered as normal. So it's within normal. So that does cut out quite a few things, such as valvular abnormalities and things like that. Although the patient may have early, may have an early valve disruption and things like that, or a septal defect. There's quite a few things that can cause it. But anyway, we won't get into that now. So let's have a look at the rhythm strip itself. So when you have a look at the rhythm strip, the first thing that strikes you is that, it's a very wide complex that we are seeing over here. But you must remember, we always follow along with what we can see, and we follow along with our, with our system, actually. So the first thing that we notice is that we've got these little waves over here. Now, these could be P waves, these could be T waves, but to my mind, they look more like P waves. So there is some atrial activity going on over there, right? That's the first thing to remember. If we had to take a PR interval, we'd look between, if you say it is a P wave, then we've got 1, 2, 2 to 2.5 to 3.5. So we've got a normal PR interval. Do we have a QRS complex after every P? If we consider this as the P, then yeah, we do have a QRS after every P. Then are they narrow or are they wide? So they're quite wide, which tells us that we should be looking at it almost as though it's coming from a ventricular origin. Is it regular? It's quite regular. In fact, it's extremely regular. It doesn't really change. And let's work out the rate. So the rate we're going to have here is about 150. So it's quite fast. So that was actually the reason why I picked this one, is because if we look at the rhythm strip, and if you look at only the rhythm strip on its own, your mind will be running towards a ventricular tachycardia, because you can see wide, complex, regular tachycardia of about 150, which is telling you that it should be that. But there's a few things that are here that are a bit worrying and which take us out of that. So the first thing is the presence of P waves. So generally, when you've got a ventricular tachycardia, you aren't really seeing P waves at any point. So that's one thing that's already making me think, okay, it may not be. Now let's look at each zone. So when we start going through the zones, let's start with the inferior zone. We start seeing over here that in leads 2, 3, and AVF, the one thing that's a little bit striking over here is that we've actually got normal narrow complexes in lead 2. So this also makes us think that it may not be a ventricular tachycardia, because once you've got a ventricular tachycardia, you have wide complexes such as what you see here. You start seeing them throughout the ECG. There's no exceptions, because a ventricular tachycardia, it can't just be a ventricular tachycardia in one part of the heart and not reflecting in another part of the heart. So this starts taking me away from that. So if we consider it's not a ventricular tachycardia, what else could it be? So let's have a look at lead 3, where again we've got these relatively wide complexes, but with these ST segments. If that's an R and that's an S, then that almost looks like a downsloping ST depression. And if you look at it here as well, this could also possibly be an ST depression, although not so much here in lead 2. If we come to lead AVR, we also see this narrow complex tachycardia going on, which again tells us, okay, this may not be a ventricular tachycardia, but we may be looking at something else. And here we can see definitive ST depressions that are going on. When we come to the septum, we see V1. We've got ST depressions and narrow complex again. And sorry about that. And then when we come to lead V2, which is also part of the septum, here we see a more conventional type of ST elevation that's going on. So we start seeing this this picture that's looking more like a myocardial infarction. When we come to V3, V4, V5, V6, leads 1 and AVL, we actually start to see that we've got these what looks like ventricular tachycardia, which is what we're seeing here. But if we start following it, and if we start looking at that, what we actually start to notice is that we've got a very elevated RS complex. Here you can see just what would be in V6, what would be like a normal ST elevation, and even in V5. But when you come to the anterior leads, V3, V4, you see more of what we call a tombstone. So there's two reasons for it being called a tombstone. The first reason, of course, being that it looks like a tombstone. And unfortunately, once you see these, it also means that that's what your patient's probably going to have very soon, unfortunately. So those are the two reasons that we call them tombstones. And when we come to the lateral side, that's when we see this, we would have assumed was a ventricular tachycardia. It's actually a very elevated RS pattern that's following similar to this. And like I say, and you can even see it in V2, it's forming like a tombstone that's going up over there. So these tombstone RS complexes are very difficult to differentiate from VTAC if you only look at a rhythm strip, for example. But once you start looking through the whole ECG and you start noticing that there's a lot of narrow complexes, that's the easiest way to make out that you're actually seeing tombstone or RS complex elevation, or let's say an RS segment elevation, which is actually quite indicative of what you call it, a severe myocardial infarction. In this case, we're going to say it's what you call it, anterolateral. And let's just see if we correct on that. So yeah, we've got a sinus tachycardia, the rate 146, we said 150, and an acute lateral MI. Right? So the rhythm strip and 12-lead ECG demonstrate QRS complexes that are wide and regular, giving the impression of a VT, which is where we started. But however, the P waves are present with every QRS complex, which is more consistent with the sinus tachycardia. So in ventricular tachycardia, you would have a similar picture, but without P waves. And to be dead honest, they normally find that they're much closer together. And generally, the tachycardia is much faster than the 140s and 150s. That would be a slow VTAC, actually, if you did have it. And as I was saying, in some of the leads, we have narrow QRS complexes, and this is more for profound ST segment deviation, mimicking wide QRS complexes. Massive ST elevations, such as seen in this case, can be easily misdiagnosed as VT when the entire 12-lead ECG is not scrutinized. ST elevation is found in the anterolateral reciprocal ST segment depression. It's found in the inferior leads, which we were seeing over there. Right? So this was the ST depression that we were actually seeing here. Not so much in lead 2, but definitely in leads 3 and AVF. Okay, now let's go and have a look at some of these, just so that we can understand what's happening, the progression of what we're seeing. So like I said, this is what we were seeing, but we had these T waves that were in there. Right? So that's what's being shown in our lead 1. So the apparent wide QRS complexes result from giant R waves fusing with massively elevated ST segment. So this is what you're seeing, the R wave and a massively elevated ST segment. The structure is formed when in leads with prominent R waves, the ST segments elevate rapidly, obliterating the distinction of the QRS complex from the ST segment, which is what we were seeing, forming essentially what is a single giant R wave, which is what you see there. Okay. There are 4 examples of giant R waves with the arrow indicating the R wave. Okay, so those are the possibilities that you can see. And then in C, we see the transition from a normal ST segment to giant RST complexes with a rapidly evolving MI. Note the progressive rise in the ST segment with greater obliteration as you go along. Right? So basically we start from there, and then you can see as the ST rises, and eventually it gives you this tombstone that's going over there. So all along here, you probably make it an easier distinction that it's an ST segment. But once you get towards the last 2 and what we had, that's when it really starts looking like a what you call it, a tombstone. So tombstone elevations are very worrying, and like I say, they show rapidly evolving MIs and very serious MIs. These patients often need to be thrombolyzed or taken in for what you call a PCI quite quickly. So what we're going to have a look at now, I'd like you guys just to have a look at this, a coronary angiogram, and this is just for fun, just to have a look at, and we're going to have a look at what happens in a coronary angiogram.
A coronary angioplasty procedure is also known as percutaneous coronary intervention. The procedure is done on blood vessels called coronary arteries. They supply your heart muscle with oxygen. The goal is to restore blood flow if a substance called plaque has significantly narrowed these vessels. To begin the procedure, the doctor will numb the skin in your wrist. A needle will be placed through your skin and into your radial artery. Next, a flexible guide wire will be passed through the needle into your artery. Then, the needle will be withdrawn. It will be exchanged for a small, flexible tube called a sheath. This permits access into your artery. You may feel pressure when the doctor inserts the sheath, but you will not feel it moving inside your artery. Next, the guide wire will be advanced up to your heart. A flexible tube, called a catheter, will be advanced over the wire to your coronary arteries. The progress of the procedure will be checked with an X-ray device called a fluoroscope. At this point, your doctor will remove the guide wire. Then, the doctor will move the tip of the catheter just inside the coronary artery to be examined. A special dye will be injected into the artery. This allows your doctor to view it better with the fluoroscope. The dye will make any blockages in the artery stand out. If a significant blockage is found, your doctor will insert a guide wire into the artery. A balloon on the tip of the catheter will be moved along the wire to the blockage. When the balloon inflates, it will expand the artery and improve the blood flow. You may feel some chest discomfort while this is happening. After this, your doctor will deflate and remove the balloon. A wire mesh tube, called a stent, may be placed in the treated area. The stent helps keep the coronary artery open. Your doctor will choose the proper size stent, which is compressed over a balloon. The stent will be moved into the artery over the same guide wire. When the balloon is inflated, the stent will expand and lock into place. After the balloon catheter is taken out, the stent will stay in place to hold the artery open. At the end of the procedure, the guide wire will be removed.
Okay, so that was just to give you an idea for those of you who maybe haven't had a chance to work in a cath lab or see how it's done. And having undergone it myself, I can tell you it's, well, luckily I don't have any stents or blockages. I unfortunately had a very rare esophageal condition which mimicked a heart attack. And well, not rare, but I mean uncommon. And they had actually taken me in for an angiogram. It's not an unpleasant experience, but it's quite amazing to see how it's done. That's for sure. And of course, I had the chance to work in a cardiac cath lab for a short while as an intern and then as an MO. And it's quite fun actually, but you really need a cardiologist to be able to see everything that's going on. But it is quite fun, that's for sure. This is about angioplasty.
A coronary angioplasty procedure is also known as percutaneous coronary intervention.
Is it showing the same one? My
The
apologies.
procedure is done.
My apologies. Sorry, this was supposed to. There is another video, but it's not that one. So here we can see what things look like on an angiogram and what you can possibly see. So this is what you would normally see if you had your left. You have your left main artery, left anterior descending that continues over there, and your left circumflex and your right coronary artery. And then as the dye is being pumped through, your cardiologist then looks for blockages along. Now, of course, the more proximal the blockage, the more the amount of myocardium that's affected. So here you can see left anterior descending, 80% focal blockage. Now, I must be honest, I haven't sat in enough to be able to tell you exactly how they work out the percentages precisely, how they work out a 60 compared to a 65 and things like that. And if anybody does know, I'd love to know myself, because I haven't sat in on enough of them. But I think they basically just look at the amount of flows and things like that, and it gives them quite a good idea of what's going on. And now we just have a look at the stenting procedure again, just so that you can see it. And we also, I think they will show the blockage in this. So we can see the blockage over there, right? It's quite a significant blockage, you can see from the arrow. So every time that they pump the dye through, they'll be able to note the blockage, and that will tell them exactly how bad it is. All right. There's the stent being moved along into the area where the blockage is. So it's exactly what they showed us in the last one. This is just showing it to under fluoroscopy, just so that you can see. It's quite an intricate and delicate procedure, and this is why when you become a cardiologist, you get paid as much as you do, and why you try and do a lot of angiograms as well. Each angiogram is basically a trip to the Seychelles. So the stent is expanded to the full size, as they had mentioned, and then the stent is left in place, and that's where you can see the blood flow now moving through. They don't always work. You do get stent failure. You do get insufflation failure. It depends on the thickness of the plaque, sometimes on the chronicity of the plaque, exact composition of the plaque. And there's also a move away from putting in stents in a few areas, because what they found is that the stents themselves actually do lead to quite a bit of inflammation and inflammatory plaque, which then actually forms another plaque within the stent and can lead to stent failure later on. So that's another thing that's being worked on, and a lot of cardiologists are now starting to look at stents as really a last resort and things like that. And I had the great privilege when I was a GP of actually working closely with a cardiologist at one of the local hospitals, where I used to send a lot of patients. I did have a large cohort of patients with myocardial problems, or with, let's say, ischemic heart disease. And he used to always advise me that as soon as I suspected it, he used to actually advise that we just give them large doses of statins immediately. And initially I found it quite strange, but and it was not common practice. It's not like a common protocol. I wouldn't advise, just anecdotes. But we'd give up to like 160 milligrams of a statin immediately, and it was quite amazing to see the different types of approaches that different doctors have based on their experience and things like that. And for any of you going into internal medicine and cardiology, it'd be lovely for you guys to also work out your own ways of doing things. So that was just a bit of fun just to finish up. And this is just a little joke as well. So I hope you guys enjoyed it. Hopefully we'll have a chance to do a case next week, and we'll try and do some ECGs and maybe some X-rays as well. Unfortunately, I am struggling a bit at the moment to get the X-ray ones done, just because of time, things like that. So the ECG ones don't take me as much time. And of course, we've got our young doctor, Dr. Paul, is also working on some presentations. So we'll try and keep it up to date on a weekly basis. Okay, I hope you guys enjoy. If there's any questions, feel free to contact me. Thank you very much. Keep well. Bye.